Good morning, my name's Leanne Harling and I'm here at the EACTS in Milan with two pioneers in Pectus surgery to talk about advances in treatment of Pectus deformities. Here I have Mustafa Yuksel from Istanbul and Ian Hunt from St George's Hospital in London.
Hi, Leanne.
Nice to meet you both and I'm very pleased to be with you today. Perhaps we could start by talking about your individual practices. It's such a diverse area of practice, and then we can move on to slightly more specific and topics within the subject matter.
Yes. I'd like to talk about the surgery of the pectus deformity. I started 2000 with the new procedure, the NAS procedure, new famous and procedure in the pectus reconstruction, and I have done until now 1,500 pectus surgery, NAS plus the Abramson procedure. But beside the surgery, there is the breast therapy and vacuum therapy. I think the latest famous treatment is the breast therapy in the pectus carinatum, and then vacuum therapy in the pectus excavatum. This means the surgery, and then there's the balance between the surgery and the breast therapy, and the conservative therapy means the vacuum therapy. And that's all. This is my practice about the pectus treatment.
And Mr. Hunt?
So I'm based at St George's. I've been practicing since 2009 and have been performing Pectus surgery really since that period. I'm very interested in a kind of comprehensive approach to patients with Pectus deformities. It's a multifaceted problem, and certainly I agree with Mustafa. I think having options around different surgical and non-surgical treatments for these sorts of patients is really the future. I think a combination of treatments may well be the right option for some patients. I think physical therapy is super important in patients. There's a lot of issues with musculoskeletal problems, posture-related issues that we see in Pectus deformities, and I certainly emphasise that importance from my patients. I think in terms of Pectus carinatum, for me, there's a cohort of patients that benefit from bracing therapy as a first-line treatment, and it's often dictated by the degree of flexibility they have still in their chest wall, which is often age-related, but not always necessarily. And then Mustafa's pioneered the role of Abraham's procedures and other surgical treatments for Pectus carinatum, and I think that will be an interesting evolution in terms of practice, and I'm particularly interested in trying to combine minimal access surgery to reduce or recreate flexibility with the Pectus carinatum patients, and then use some form of bracing therapy as an adjunct to their treatment. So that's a particular area I'm interested in, and certainly we've started looking at small cohorts of patients where that's been very effective. In terms of Pectus excavatum, Mustafa's been a pioneer in developing procedures developed by Donald Nuss in relation to the Nuss procedure, and I think that's a very interesting area that you're increasingly looking at different ways of treating patients with modifications of the Nuss procedure, using different techniques, different numbers of bars, different positions of bars to support patients with Pectus excavatum. And I still think in my practice there is a role for the modified ravage in some small groups of patients where they have such a severe deformity and particularly a very distorted sternum. So I still recognise a small number of patients where, for me, the sternal rotation is still an issue for performing a Nuss procedure to give a very satisfactory result. So I still have a small group of patients where we offer that rather traditional but very useful operation. So I think coming to the patient with a comprehensive approach, combining lots of different treatment options, including physical therapies, I think it's the way forward.
Yes.
So for both of you, in your initial assessment of these patients, because it's very holistic approach required for these kind of difficult cases often, how do you go about setting up the initial consultation with the patient, the perioperative care, because it's something that obviously needs to be right? Yeah. What's your protocol, as it were?
I'd like to stress about the pectus surgery. Pectus surgery is not the cosmetic surgery. I mean, there's the big conflict some country like the England. I mean, they say it is the reconstructive surgery, but not the completely the cosmetic surgery because of some of the patient. I think 30% or 40% patient has need the reconstruction for their health, not their cosmetic reason. I mean, um, I decided before the operation how to prepare the patient. Usually the deformity, if the deformity is mild or the large, before operation, if the patient has no complaint, I decide to operation, mainly NAS operation. And some complex deformity, I am doing the complex operation, NAS plus Abramson operation. It is called the sandwich operation. And then if the for the cardiothoracic patient, I decided I calculate the pressure, the deformity pressure. If deformity pressure low, less than 10 kilogram per surface, and I started the breast therapy. Breast therapy is most favorable therapy, I think, in the cardiothoracic patient. If the pressure is the high, I send the patient directly the Abramson operation.
How do you work up your...
Yeah, it's interesting. We started the bracing therapy about 4 years ago. We've now treated around 300 patients with bracing therapy, with about 180 patients with good outcomes, completed their programs. We started introducing a pressure gauge to our practice about a year ago. We measure a PSI as an initial assessment, and then we follow that patient up with repeat PSIs. The pressure assessment, I think, is really helpful, particularly for a novice starting a program. I think it gives you a quantifiable measure of flexibility. I think Mustafa has magic fingers. He can measure pressure very easily, but I think if you don't have that level of experience, I think it's a useful adjunct. And I found for us, we use a cutoff of 14 psi. That seems to be a cutoff for the degree of flexibility. If it's less than 14, there's still a degree of flexibility in the chest wall to allow a bracing therapy to leave the patient with a successful and, most importantly, a permanent correction. That's one of the really important elements of bracing therapy, not to offer somebody a treatment option which doesn't give them a permanent correction. 14 psi seems to be a magic number. I think if it's less than 10 psi, I would agree with Mustafa. I think that would be a very good candidate for bracing therapy. I think between 10 and 14, I think you need to counsel the patient that they may not get a complete correction, but generally we find that they will. Over 14 psi, that's where it becomes more difficult, and I think that's where different techniques, surgical techniques, may evolve, which allow those groups of patients to be treated. For us, around Pectus carinatum and bracing therapy specifically, what we spend a lot of time doing is developing a program around the commitment to bracing. So bracing is all about compliance, and the failure rates amongst papers around the world is being the issue of compliance. So what we've found is we have a very prescriptive program, and we work very hard to make sure the patient follows that program, because fundamentally, if the brace is not being worn, it won't work. So that's really a big emphasis for our program, that we use that technique to, that the idea of a program, a prescriptive program of bracing therapy with a tailored approach to each patient has really made the program very successful. But it's a lot of work and a lot of commitment by the patients.
I would like to say something more here at this point. In the country, must be special centers for the treatment of the Pectus patient because of the transplant. I know the Ian has a nice center to collect the Pectus patient, and then to decide this way is the breast therapy first, and then surgery second, or another option. Also the excavatum patient first, the vacuum therapy, also the vacuum therapy, and then start the exercise program or something else, and also psychological support for this patient. That's why, for example, in London or in Newcastle, any other way, experienced surgeon, experienced chest physician must be together and start the program, not the individual surgery or the treatment. Because of I have learned in this therapy 15 years. Initially I have never known anything 15 years ago, but now I know. I need the center, I need the chest physician, I need the therapist. That's why I offer every country has a special center of Pectus treatment, not only the surgeon,
I mean, from a UK perspective, we're currently being challenged within the NHS to justify how Pectus surgery is effective in terms of functional improvement of patients, and we'll touch on that in a minute regarding Pectus excavatum specifically. But the direction of travel is we have to justify these procedures, whether it's bracing therapy or surgical procedures. And I would absolutely agree with Mustafa. The UK experience is that, for example, only 300 cases a year are performed for Pectus surgery around the whole country. And if you look at where those operations are being performed, it may only be in 4 or 5 centres. So you need to concentrate the level of experience in an otherwise quite a small number of procedures to get the experience that Mustafa has and that you need to develop to allow patients a very much more comprehensive approach to their treatment.
Yes.
So be able to offer every option that's available in a centre which has an experience with physiotherapy, chest physician support, cardiology support. So that, I think, is the future again, to focus everybody's attention on developing these specialist centres.
Yes.
I agree.
Yeah,
I agree.
I think so.
Yeah. I mean, I think we need to touch on the rather diverse issue of function.
Yeah.
There's a lot of discussion around Pectus excavatum specifically and functional issues.
Yes.
I would echo Mustafa's point around patients having symptoms. Certainly in our cohort of excavatum patients, I would suggest that a third towards 50% of patients will come to see me with symptoms. Those symptoms are very specific. The symptoms are usually breathlessness on exertion, a feeling of fatigability, often exertionally related, and can be quite profound. And the difficulty at the moment is there is a disconnect between what patients are complaining of and what investigations we are using to investigate these problems. And I think we're playing catch up. So I think a transthoracic echocardiogram in a non-specialist hands is going to be normal in the majority of cases, regardless of the severity of the deformity. What we're finding in our practice is that as our cardiologists become more familiar with seeing patients with Pectus excavatum, they're starting to recognise there's nuances, particularly around exertional functional problems, and certainly concentrating on areas such as tricuspid valve morphology is a very interesting area. And we've found, particularly using cardiac MRI, that we're starting to identify morphological problems with the heart which weren't previously identified. So I think there is a functional element, and we're just not identifying it because some of the investigations I don't think are sensitive enough. Particularly doing a simple transthoracic echocardiogram, I don't think is good enough for patients that we're dealing with, and not least the windows can be very poor quality as well.
Yeah, I think another reason for the center, for the team, after the Nuss and Abramson operation, we leave the bar inside 2 or 3 years. In this time, the patient needs the psychological support and medical follow-up, and that's why 24 hours, the surgeon and the therapist can be eligible for the patient. If the patient take the phone and then somebody reply them as soon as That's why it is necessary the team 24 hours and all year, all time to follow up this patient.
Yeah, I would agree.
Can I ask about your functional assessment of the patients? Do you have a protocol for preoperative assessment?
Yes, I'd like to say, first of all, we are doing the lung function test and just chest X-ray. If the patient has a complaint, we send the echocardiogram and the blood test, and that's all. And the anesthesiologist consultation. And simple, but just option the echocardiogram if the patient has a complaint. Otherwise, just chest X-ray, ECG, and then function test and blood test.
Yourself?
Very similar approach, and but sending to a specific cardiologist who is used to dealing with juveniles, because most of my patients are young adults or children. Particularly cardiologists are interested in morphological exertional problems. So we're lucky at St George's to have quite a robust cardiology group that have an interest in young athletes particularly with hypercardiomyopathy type problems. So we have an advantage that we can send our patients to see this sort of group of cardiologists, and we've found that's very helpful. Cardiac MR seems to be quite useful in some instances. So we're exploring different cardiological investigations that are identifying problems with our patients, and the severity of symptoms often dictate what level of investigation we will take the patient to. Just to add to what Mustafa has said, it's interesting. So I'm a thoracic surgeon. I perform lung resections like Mustafa. I do most of my operations keyhole, and when I started doing those operations back in 2009, I was struck by the volume of patients I was operating on, how improved their symptoms of pain were after the surgery. But it took a volume of patients to see, and it was something quite nuanced. And I think, again, it reflects the importance of having Pectus patients being monitored, looked after in specialist centres, because it's only with volume do you start understanding that patients with symptoms of breathlessness on exertion, for example, when they have their operation, particularly when they've recovered from the surgery, their symptoms are often improved. And it's only when you see lots of patients telling you on a regular basis, I feel better, I feel better, the constrictive feeling they often complain about has gone. And it's a very interesting thing I've developed as my practice has grown, that the volume of patients I'm seeing and this rather nuanced symptomatology that they're now saying they feel better, with their chest wall corrected, is something I'm starting to realise. And I think you need a volume of patients to study, and that's something we're very interested in developing in the UK. Studies where you have a large volume of patients, which is difficult to identify these patients which will benefit from a functional perspective.
I'd like to add something. If the patient 20%, we have seen the scoliosis. If the patient has slight scoliosis, we send the orthopedic consultation before operation, because of which one the first treatment. The other one is if the patient has a complex anomaly, like Marfan syndrome or the Noon syndrome, we send the genetics to consultate about the other way. The others the same. The echocardiography. Usually, if the patient has some complaint about cardiac, we send the cardiology consultation routinely, just 10% or 20% patient.
And it's interesting about the indications for pectus excavatum surgery within a Marfan setting, that we're now offering combined cardiac surgical procedures with a pectus correction. And that's something, again, if you have a large volume of practice, there are ways you can perform these operations as a combined procedure safely. So one of the concerns that cardiac surgeons would have is if you're doing a fairly aggressive reconstruction of the chest wall, issues of bleeding after surgery, etc. But there are ways you can, we do a very simple open NUS procedure where we use bars with patients having cardiac surgery for their underlying aortic problems or etc. And that's a very nice combination of procedures that often give patients both benefit from management of their cardiac problem, but also benefit from improvement of their correction of their chest wall. And that's something we're also interested in developing.
Does that have any implications from an emergency reoperation perspective?
Very good. So you need to be very clear with your residents about how they remove the bars in a hurry, and we use a very simple protocol that we have the instruments available at the bedside, and if the patient were to tamponade or there were to be a problem, they can remove the bars in a very simple way immediately so it doesn't stop emergency stenotomy being performed if necessary. Hasn't happened yet, but yeah.
And if we maybe move on a little bit towards talking about surgical strategies, there's clearly been a huge move towards doing minimally invasive surgery, both for carinotums and excavatums, more so obviously in the excavatum group. Perhaps could you talk about a little bit about that in your practice and how you would select those patients that are appropriate, or are all patients appropriate for minimally invasive surgery to some degree?
There's the little, I think in my practice, 10% did the open surgery. I have a practice, still I am doing the Ravitch operation. Open surgery there is the option for some difficult patient. For example, arcuatum, there's the big deformity about the carinatum, the high deformity near the manubrium sterni. The deformity is just can be corrected with the Ravitch operation. That's why Ravitch the still option to treatment of the complex deformity. That's why I hate ravage operation because of the long and too much bloody operation, and then difficult to patient recovery period. And but there's still option for some patient.
So similar number actually. 10% of my patients would have an open procedure in the excavatum group, and 90% would get a NUS procedure. But it's interesting for me. I think Mustafa's experience is greater than mine. I still use sternal rotation and depth as an indication for an open procedure versus a NUS. And so I've had several patients where the sternum is essentially completely rotated, and I find, personally, I think the aesthetic result is better for me, in my hands, with a modified NUS, but Mustafa has a lot more experience with NUS procedures than I am. Just a comment about more complex procedures. I think horseshoe pectus arcuanutum, I think that's always a challenging deformity. It's a mixed deformity with combinations of carinatum and excavatum. They're usually not amenable for any bracing therapy because of the nature or the etiology of the deformity, and so I think they often do benefit from open procedures as they offer a much more complex problem.
And how about minimally invasive surgery for the carinatums? Because I know that's something that's a little bit contentious within the literature.
I think it's difficult because these patients are not generally coming to you with significant symptoms, and the modified ravage is a very aggressive break and reset of the chest wall, and I think you need to be very clear with the patient, what the indications for surgery are. Rather interestingly, in our group of carinatum patients, we have 300 patients now that we've treated for bracing therapy. 30% of patients will still have symptoms, so there's obviously something we're missing regarding why patients have symptoms of breathlessness with carinatum when there's clearly no functional cardiac or pulmonary issue, and I suspect it's something to do with the way the chest wall moves. I think it's a chest wall dynamic issue. The mechanics of the chest wall are somehow affected, and it's often exertional breathlessness. So in my practice, the vast majority would be offered a bracing therapy. We have a small number of patients, usually age-related, so they will be over the age of 20, with a stiff chest wall. In Mustafa's practice, it would be Abraham's procedure.
Yes.
In my practice, what we'll be doing is using a very limited ravage operation where you're doing very small incisions. You're basically shaving the cartilage down and doing one partial osteotomy, and then you're using a bracing therapy treatment subsequent to that. And that's been, in a small cohort of patients, very successful in combining two different approaches. So the idea is you create flexibility through a small operation, less morbidity, quicker recovery period, and then you're adding bracing therapy to that treatment option for a period of 6 months to a year to allow a permanent correction. It does require patient motivation, and that's one of the problems. Patients often self-select that they want a quick fix. With bracing, it's not a quick fix. It's a prolonged program which requires compliance, and they need to sign up for that. And I think that's one of the problems I found. The psychological element that you need to get patients on board for.
Perhaps we're sort of running a little bit with time, but maybe we can talk about your use of the Abraham's procedure, because that's something particularly novel, which I'm sure people will be very interested in hearing about.
Abraham's procedure, in my opinion, there is if the patient has a pressure is higher than 10 kilogram, according to my device, I am putting the bar, like the Abrahamson explained. Usually we leave the bar 2 years and then remove the bar. But in other way, I started 15 years ago the Abrahamson procedure. So far I have nearly 200 Abrahamson operation I have done. But the last 3 years, now I have the breast therapy, more than 500 patients I have. Now I believe that the breast therapy is the most favorable treatment for the patient because of cheap, easy to apply, and anytime patient can leave the breast. And that's why I think the breast therapy must be some protocols, and some therapists start the breast therapy, and every month or every 3 months follow up properly. The treatment will be the option for the carinatum patient. And just the stiff thorax or the patient, if the more than 25 years old, the surgery must be option for this little patient. Not to every patient sent to operation, in my opinion.
And Mr. Hunt, one of your particular interests is bracing, and I know you've been doing something very novel with the non-compressive bracing.
It's a very simple technique. So we use this thing called manipulation, which is basically a physiotherapy, sports physiotherapy technique of soft tissue release. So you do a kind of massage prior to performing the procedure. Very simple, takes 20 minutes. It involves warming the chest, using local anaesthetic to numb the skin, and then using infrared massage, and then a physiotherapy technique where you're just pushing on the cartilage in patients with flexible chest walls. This is patients with low PSIs, young patients, and the idea is that you correct the chest wall and then position the brace. And the idea of the brace is then worn for a period of time. In our program, the brace stays on for 5 days without being removed. Again, a commitment by the patients, but you need to get them on board. And then we start the program with a very intense wearing schedule where they wear the brace for 3 months, essentially permanently, just removing it for short periods each day. And then we start a weaning program. So the way we've developed our bracing schedule is to do all the intense work at the beginning. And what we've found with that method is that the compliance is much better. The patient, if they feel they're improving very rapidly, they see an improvement within a few days of starting the therapy, they're much more likely to complete the therapy. And I've studied various bracing programs around the world, and if you set the schedule up so that you're doing it in reverse, which is what traditionally would happen, that you would start wearing the brace very slowly and slowly build up the program, we found that the compliance was much lower. People gave up. They weren't seeing an improvement. They were committed with time, but without seeing an improvement, therefore they stopped wearing the brace. So we've changed the scheduling, and by wearing it very intensely at the beginning and then slowly weaning it off over a period of time, we found that our compliance rates are I think, much better. And I think that if you can get the patient to wear the brace for the period that's required, the opportunity for permanent correction is very high.
And yourself, with regards to compliance, do you think there are any key sort of pearls of wisdom to improve patient compliance?
About the breast therapy, and I mean, in my patient, usually it's 6 months and 1 year between the patient gets the result. But we need some more support to the patient about the way of which one is the best. Otherwise, I mean, I noticed that you have a nice follow-up program. I have to learn to like your program. I started my patient. I am trying to learn the breast therapy more than surgery. I think in the future, more breast therapy must.
But like lots of things, it's nuanced. So as you learn, I learn every time I have a patient. I learn something subtly new, and I think it's just developing that body of experience. And certainly I found bracing therapy is like that. You just so many little nuances that you suddenly realize. For example, having the therapy much more intensively at the beginning seems to really help the final result, because patients are much more committed to wearing the brace. So changing the program to allow intensive wear at the beginning seems to make a big difference in our program.
And so finally, really, where do we go from here with regards to innovations in pectus surgery, and how we're going to show the community that this is an important entity and needs to be taken forward?
About pectus surgery, I mean, the surgery is simple, but difficult. I mean, a simple 15 minutes, but there's the result something mortal. I mean, that's why the training program must be very be cautious. I mean, don't underestimate the surgical program. And the other way, in the breast therapy and then vacuum therapy, must be treat the new generation. I mean, new surgeon and new chest physician. The other way.
I mean, for me, it's applying thoracic surgical rules. If I have a patient come to see me with a lung cancer, I will offer the right operation for that cancer. Pectus needs to be the same. You need to have a comprehensive approach. You need to see surgeons who have experience, that means volume, and they need to have an opportunity to offer them any treatment that's appropriate for that patient. So it's an opportunity that if you see a patient in front of you, that a brace would be the best option. A brace is what they get offered. If it's a NUS operation, a NUS operation. A ravage, a ravage. So you need to see a surgeon who has expertise and experience in all facets of Pectus treatment, and that requires volume, and that requires specialist centres, essentially, I think.
International collaborations.
Yeah, another point, I mean, the NAS operation, it is not like the every year 2 or 3 operation. You couldn't do. I mean,
no.
You have need the center. Your volume must be a year more than 20 or 30. I don't know. And then that's why it is easy operation, but the result is sometimes the mortal or morbidity can be high than you expect.
Indeed. I mean, it's interesting, the UK experience, because of the SCS database that we have access to, we know that very few centres do more than 20 operations in 2 years, let alone 1 year. So you're absolutely correct. You need to have a centre which has a volume of practice, and for me, I agree, create 20 to 30 cases a year at least to develop that expertise.
Yes.